Thanks for the introduction. Thanks very much for letting me speak today. So I'm going to do a talk about bronchiolitis. Might be quite a lot of information on the slides, but I'm hoping if people find it useful, you'll be able to refer back in future on the YouTube channel. I'm going to try and keep it fairly practical as well. So certainly in Belfast, we were starting to see a lot of bronchiolitis again at this time of the year, and I was up all night on a couple of nights ago picking one up, bringing them to our intensive care unit, and we're seeing them quite frequently now. So it may well be that this is the most common presentation that people are dealing with as paediatric emergency and anaesthetic teams currently. So a bit of background, bronchiolitis is an acute viral lower respiratory tract infection, and by definition, it affects children under 2 years old, most commonly caused by respiratory syncytial virus, or RSV, and it is the leading cause for hospital admission in children in the UK under 1. In fact, 2 to 3% of all children are hospitalised with bronchiolitis. And the seasonal peak traditionally has been October to April in the Northern Hemisphere, but over the last few years, probably subsequent to COVID lockdowns, we've seen a bit of a variation in the seasonality of RSV, and we're seeing it even in the summer over the last few years. Most of the cases will be mild and self-limiting, and a small minority of those will require admission to PICU, those that end up in hospital, and then an even smaller amount will require mechanical ventilation. And in well-resourced settings, the mortality rate is very low, but it is significantly increased in infants who have pre-existing conditions as cardiac, respiratory, or neuromuscular conditions that make them more vulnerable. And there is a significant mortality burden globally in areas that have less healthcare resources. In terms of presentation, I'm thinking most people here will be familiar with this, but it is a clinical diagnosis. So starts usually with nasal congestion, sneezing, cough, possibly fever, reduced feeding as a consequence usually of the nasal congestion. And then it progresses further over the next sort of 48 to 72 hours into increased respiratory effort, potentially with grunting, head bobbing. On examination, you might hear wheeze and crackles and focally reduced air entry in some parts of the chest. And also you'll see an elevated respiratory rate, possibly elevated heart rate. Hypoxemia, if you check the SATs, and certainly in children that are hospitalized, and apnea, which is especially a feature of the disease in children who are under 2 months of age or who are preterm. And often in those particular age groups, apnea may be your first presentation. You might not have any other symptoms. The first thing that happens might be that the baby stops breathing. This is just a little kind of summary of the signs, symptoms, pathophysiology, and kind of a duration of symptoms, what you expect to see. So you can see this kind of peak between sort of 3 to 6 days, where very much you have this minute-to-minute variability in symptoms. So you have a baby who might work hard intermittently, who might suddenly work a lot harder and then might sort themselves out if they cough or they're repositioned. You might find that if you listen to the chest, you'll hear focal crackles and focal reduced air entry 1 minute. And then if you listen 5 minutes later, that part might be clear, but you might hear some reduced air entry elsewhere. You might hear intermittent wheeze. So very much a very dynamic respiratory status that they have in this period where there's lots of mucus. And you can see down at the bottom, this histological photograph, you can see the nice open normal bronchiole. And then what happens in bronchiolitis is that it gets all swollen. The wall of the bronchioles get very swollen, and then you get all this crud basically in the airway, in the small airways that plugs it all up. That's caused by the sloughing of the epithelial cells as the virus has kind of infected them and caused them all to kind of fall apart and drop into the lower airways. And this is obviously what causes the cough and the obstruction. Investigations for bronchiolitis, there are actually no definitively indicated investigations. So you can monitor patients with bronchiolitis using pulse oximetry and with your clinical assessment, i.e. how do they look, what's their heart rate doing, what's their respiratory rate doing. There's nothing really otherwise that sort of is really necessary to guide your management other than in some particular circumstances. So respiratory PCR tests we use to identify the pathogens, and that helps with cohorting these patients in different parts of the hospital. Other things you might want to consider, so if you've got an infant who's under 8 weeks old and has fever, you probably should consider a septic screen, even if you have a kind of a feeling that this is bronchiolitis. And also, if you suspect that your differential might include pertussis, i.e. if there's really prolonged coughing spells that are associated with desaturation and apnea and vomiting, you might want to consider a full blood count to look for lymphocytosis, as well as your nasopharyngeal swab for pertussis and your respiratory PCR strip. Blood gases and chest x-rays are actually not routinely indicated, but you should think about them when you've got a patient who has severe disease, or you think there might be a complication, or also where there might be an alternative diagnosis that you suspect. Because if you're seeing 100 bronchiolitis every day, there will be the occasional patient who has something else, and that might lead you to look further. On the right there, you see an x-ray, which is fairly typical of a progressed bronchiolitis. So you get this right upper lobe collapse and then lots of fluffy changes everywhere else. But often, actually, there's not really any changes, not really anything significant in the chest x-rays, even if there are significant findings in auscultation. In terms of management, it's important to, this is always emphasized, I suppose, when we're talking about bronchiolitis, but there is no effective therapy for bronchiolitis. There are a big long list of things that don't work and that are not recommended. That includes bronchodilators of any form, caffeine, antibiotics, adrenaline or hypertonic saline nebs, corticosteroids, regular nasopharyngeal suctioning, and sevoflurane. Just additionally, in the small print there, however, if you have a baby who's over, or child who's over 6 months old and has a predominant wheeze pattern when you're listening to them, and they have, or they have an atopic history, say with allergies, eczema, hay fever, things like that, you can try there's nothing wrong with trying bronchodilators, but do stop them if it doesn't help, because if you give lots of bronchodilators to small children, it actually ends up making them work harder. And if it's not helping with wheeze, if it's not helping with bronchospasm, then it's not worth doing. What does help? Well, the best available treatment we have for bronchiolitis is simply time and patience, which we don't, I suppose, as medical professionals, we don't do very well. We don't have a lot of time and we don't have a lot of patience. And also, certainly, parents don't have a lot of patience either when this is going on. They want you to fix their child. But ultimately, supportive care is the absolute mainstay of management here. So give oxygen if your SATs are below 90%. Try nursing on their front, prone, just turning them around and moving them around. That helps move things around in the chest, might make them more comfortable. But emphasize to the parents that you're only nursing prone with monitoring attached, and it's not safe to do this in the household. They can be done in a safe area if you're talking about small infants. Support their fluid status, but do reduce their intake to 50 to 70% of their calculated maintenance, because these children do have a tendency to hold on to fluid. Provide nutritional support, so nasogastric feeding, whether that's continuous or small volume comfort feeds. Suction the airways as required, so don't do it as routine, but you may have to suction the nose if they get into difficulties and they need a bit of help getting some secretions out of the nose or out of the upper airways. Most of all, minimal handling, so just stop annoying the babies. And that might include the parents. So sometimes the parents will want to nurse these children, want to be all over them because they're worried about them. Sometimes you just need to say to them, hands off everyone, put them in the incubator and just leave them alone. And you have to watch and wait. We frequently in ICU get calls from DGHs worrying that these children may get worse, they might tire. And that's obviously a possibility, but the vast majority of these babies usually get better in time. They do usually get better. If you watch and wait, they kind of sort themselves out. You leave them alone, they mostly sort themselves out. Caveat by saying, escalate sooner in vulnerable infants. Those infants I mentioned that have cardiac and respiratory problems and neuromuscular issues. So what if they do get worse? So how do you tell? So babies with bronchiolitis might show signs that they're getting tired, as people say, or respiratory exhaustion. Again, another thing just to think about here is be wary of those children with neuromuscular disorders. So things like SMA and spinal muscular atrophy, they may not be able to show signs of increased work of breathing or increase the respiratory rate. So think about increasing heart rate and respiratory rate. If those are both going up, that might be a child who's struggling more. Worsening hypoxemia, so if you're struggling to keep your SATs over 60%, if you're struggling to keep your SATs over 90% with 60% oxygen, that's a sign that you probably need to escalate. If you've got increasing work of breathing, if you've got more frequent and severe apneas, so small pauses of breathing in small babies especially, may be a feature and not necessarily a reason to go to ICU or escalate care. You might just need to give them a bit of a nudge now and again or a bit of a poke. But if these are becoming more severe, more frequent, if they're associated with profound desaturation of bradycardia, that's probably an indication to intervene or increase their support. Things that I would look for that show that maybe things are really going on a downward spiral would be grunting, which is auto PEEP that the baby's generating, trying to keep the small airways open, pallor, lethargy, and a slowing respiratory rate in this setting, because that might be a sign that they're not able to keep up anymore. And if you see these things happening, that would probably be an indication to increase your respiratory support. And we usually do this sequentially now: high flow to CPAP to invasive ventilation. And I would say if you see a baby who's really struggling like this, you maybe should consider antibiotics at this point in case there's a superimposed bacterial infection. So the support that we use is fairly well established now. So high flow is usually the first step. It's useful because a lot of pediatric wards will do this. I think most pediatric wards will do this. It's easy to apply and it's very easy to use. Delivers humidified supplemental oxygen via specialized nasal cannula. And generally we would say to initiate at 2 liters per kilo per minute. And evidence now is very well established that it's associated with improving symptoms, so greater comfort for the patient, reducing the length of hospital stay and length of oxygen therapy, and reducing the need for escalation of care versus standard oxygen therapy. But the most important part here is that there is no increase in adverse events. So even if you think high flow maybe doesn't work as well as we all say, it doesn't actually make anything any worse. It will make the baby more comfortable, so it's potentially worth doing just for that. How does it work? Probably delivers a small amount of PEEP, 2 to 4 centimeters of water, helps to wash out the anatomic dead space. If you've got a baby who's breathing really quickly and has airway obstruction, they're going to be rebreathing a lot of those gases. So it helps wash those out with oxygen, and it humidifies, so it's better comfort at greater flow rates. CPAP, so that's the next step up usually. That delivers PEEP, keeps those smaller airways open, and reduces the work of breathing for the baby. This is usually considered HDU level care, and pediatric wards may not do this. When I worked in Scotland, there were some wards who had HDU settings who would initiate CPAP for small babies, and that was very useful. It is simple to use, but some interfaces can be tricky to attach. However, it can be delivered using the nasopharyngeal airway. It is less comfortable than high flow for babies, but it gives more respiratory support. And for those smaller apneic babies, it also gives them some nuisance value, i.e. it stops them from stopping their breathing. And you usually start at a PEEP of 5 to 6 centimeters of water. So in terms of mechanical ventilation and intubation, indicated if your escalation through respiratory support isn't working. So you've got worsening respiratory failure despite all the steps you're taking to escalate. You've got persistent apneas or significant apneas that require intervention, i.e. bagging, and hemodynamic instability. And in which case, if you have hemodynamic instability, I would suggest you review the diagnosis. And then if you've got a baby who has an impending or who has actually had a respiratory arrest, I think that would also be, I think most people would consider that a reason to intubate. We'll go through some preparation and things you should consider with this, because in my experience picking babies up from district general hospitals with bronchiolitis, I think people often do want to intubate, and often quite quickly actually want to kind of move on and escalate the intubation, but then they tend to struggle quite a lot with these babies once they've done that, because the hard work is still to be done once you've decided to do that. For the most part, I find that after the gas that's done before intubation is better than the ones that I see after intubation when done in most district general hospitals. And that's my general experience, because there is a real difficulty with ventilating these children afterwards. So I would advise that you pre-oxygenate the child with PEEP if you can via a Mapleson circuit. So you offload the work of breathing and give them a bit more support. If you can't do that, just keep the respiratory support that they're on, their high flow on, until you're ready to kind of support their airway, and turn the oxygen up to 100%. I would pass an NG tube so you can empty the stomach of feed and air, and have someone who can intermittently or continually aspirate so that the stomach doesn't blow up. Ensure that you have your continuous pulse oximetry, non-invasive blood pressure and cardiac monitoring. Make sure you have at least one working IV line, preferably 2, but use an IO if you don't have one, so that you can get things done quickly. And prepare a fluid bolus, as these children might be relatively dehydrated and you might get some hypotension when you give your induction drugs. In terms of the team, this might be a shared process between pediatrics, anesthetics, and ED. So you should define suitable roles depending on the sort of the skill set. Consider using the most experienced neonatal intubator if dealing with a small infant. That might be a neonatologist rather than an anesthetist. And anecdotally, I have had some anxiety with intubating small children with anesthetists who don't have to do it very often in DGHs. And so it might be worth having a discussion about who the best intubator is. Consider the setting for intubation. Should you move to theatre or to the intensive care unit? If it's a neonatologist intubating, I would suggest that anesthetics still prepare and give the drugs, because although I might be out of date, but generally, I think the neonatal approach to induction is an opioid, i.e. fentanyl, and then succinylcholine, and this just won't be appropriate for babies with bronchiolitis. And anticipate potential problems and prepare your plans. So any features of the challenging airway, these babies normally will have a standard airway, won't have a majorly difficult airway, but the whole situation will make it more challenging. Look for any features of hemodynamic compromise. Again, consider your diagnosis with this and speak to your regional ICU and your retrieval service for advice. In terms of preparing your equipment and drugs, so it suggests use ketamine 1 to 2 milligrams per kilo plus or minus fentanyl 1 to 2 mg per kilo plus rocuronium for your induction, and consider having some atropine close by. I would suggest using this mix even if you're more familiar with other anesthetic drugs, because this is the most cardiostable kind of induction. It's the standard that we use in ICU. Ketamine will give you some tachycardia, which will help with your cardiac output in these infants. You might want to, if you're thinking about using propofol or sevoflurane, it's probably going to be okay most of the time, but I've said to keep thinking about reviewing your diagnosis. And there are at least 1 or 2 children who look like a bronchiolitis every year who turn out to be a myocarditis or a cardiomyopathy. And if you use something that kind of causes more depression of cardiac function, you might get into difficulties with that. So I would suggest just sticking with kind of our standard of ketamine and plus or minus fentanyl and rocuronium. Straight blade is usually recommended in small infants for direct laryngoscopy, but you should use the equipment you're most familiar with. The most familiar video laryngoscope probably is first line. I would suggest a microcuffed DT tube with a stylet as primary oral intubation, but do consider an uncuffed endotracheal tube, particularly in infants who are under that weight range of 2.5 to 3 kilos. You should have inline continuous waveform capnography and maintain it in the bagging in the ventilator circuit. Consider the ventilator circuit you're going to use post-intubation and look at the dead space you're going to create. Use an appropriate pediatric ventilator and circuit if you have one. It might be worth thinking about getting a neonatal ventilator if this is a very small baby, or a transport ventilator that has infant circuit and settings for very small infants. And do set it up. Make sure it's all calibrated and set up well before you put the baby on the ventilator. Other considerations with the patients in particular, so infants and neonates have a relatively at baseline reduced respiratory capacity versus older kids and adults. So they're obligate nasal breathers when they're very small, so they're very narrow airways. Cartilaginous ribs with highly compliant airways and chest walls, so they're very prone to collapse, and that's why you see all that recession when they're working very hard. Gastric dissension will splint their diaphragm and make it harder for them to breathe and make it much harder for you to bag them. They proportionally greater anatomical dead space, and they have a lower functional residual capacity. And with all that in mind, they also have an increased basal oxygen consumption and metabolic rate, all of which will be made worse by bronchiolitis because their heart rate will be up, their breathing rate will be up, and they'll have less lung capacity. They'll have more sticky airways, narrower airways. So all the things are made worse by this. In terms of their anatomy, they have small mouths with relatively large tongues, relatively large floppy epiglottis, lacks thyroepiglottic ligament. So this is why we talk about using a straight blade to lift the epiglottis directly, because if you go into the vallecula and lift, you might see this floppy curved epiglottis hanging over your vocal cords. The vocal cords are relatively high and anterior versus older children and adults, and they have dominant vagal tone. So if you instrument this airway, you can cause profound bradycardia. And I suppose the summary of all this is, even if you pre-oxygenate really well and optimize them really well, these babies are very likely to desaturate even with all that. And you will be doing a modified RSI, and these babies, you will have to bag them when you've rendered them apneic with your drugs and your paralysis. Positioning is important for small babies, so keep the head in the neutral position or with slight extension. Avoid excessive flexion or extension, and think about shoulder elevation. You can see in this picture, there's kind of what a bit of shoulder elevation does in terms of bringing the cords into view. Post-intubation, so the work doesn't finish when the tube's in. Actually, sometimes the hard work begins. So you need to secure your ET tube and be prepared to manually ventilate the child with the bagging circuit through the ET tube. Bear in mind, these are very small, delicate lungs, very small tidal volumes, so bag gently. Secretions are likely, unless this is a baby who you've intubated for apnea, who's just stopped breathing and they're very small and very early on in their disease course. Secretions otherwise in other infants are likely to be a major problem. So be prepared to suction the ET. and you should bag through maybe a 0.5 to 1 ml of saline to help loosen mucus plugs. You might have to do this multiple times to try and get as much out as you can. Chest physio at this point will be helpful. So if you can do a wee bit of amateur chest physio, or there's a physio nearby who can help, that will actually help to optimize things. Feel the airway resistance while you're bagging, and feel the turbulence on the bagging set before attaching to the ventilator. So if you can feel that the baby's still got a lot of stuff down there that you need to get out, it might be worth kind of still bagging, still trying your suction before you set them up on the vent. Initial ventilator settings that I would suggest. So try, if you can, we in our unit, we pick a tidal volume mode, but you can also use a pressure targeted mode. So I would suggest aiming below 30 to start. You're trying to get the chest to move adequately, and you'll be aiming with your pressure to achieve a tidal volume of about 5 to 7 mils per kilo. Set your initial PEEP to 5 to 6. If there's a large collapse or consolidation on the X-ray, this potentially could be increased to try and recruit more lung volume. Keep your rate physiological, so between 20 and 30. Probably start at the higher end initially and then reduce if you can. Inspiratory time, usually 0.7 to 0.8. You might be able to, sometimes when I'm transporting these children, I might prolong that slightly if I'm struggling to hit tidal volumes with the pressure I've dialed in, but I would usually stick to 0.7 to 0.8. Aim for oxygen saturations over 88% and your end tidal CO2 between 5 and 10. And if your pH is over 7.25, that's probably okay. You probably don't need to thrash these lungs. There is a risk of ARDS with children with bronchiolitis. There is a risk of gas trapping with a concurrent risk of pneumothorax. So try not to thrash the lungs too hard, and trying to accept a bit of relative hypoxemia, a bit of relative hypercarbia. People do struggle after they've intubated and they've tried to get on the ventilator. So basically go back to the principles of the DOPES assessment in terms of trying to address the problems you're having with ventilation. So working through that in order. So D for displacement. So confirm your ET placement with your waveform capnography, and then get the chest X-ray quickly so that you can see what positions it's in case you need to move it up or move it down. So in very small infants, a 0.5 centimeter can make a huge difference. So get the X-ray to see what you have to do, and then measure it out on the X-ray to see where you need to position it. Obstruction is probably going to be your major problem. So you might need to suction frequently, and mucus plugging is very common. And I've had ET tubes block on me with children with bronchiolitis when I've retrieved them, when I've been doing all this before I put them in the ambulance. If you hear wheeze, it's almost always secretions. I have to emphasize that. It's almost always secretions. So try and clear the child's chest and clear the ET tube rather than reaching for bronchodilators. Assess for pneumothorax. So if you have the ability, use lung POCUS to do that, or use a chest X-ray and aspirate if indicated. If there is a big pneumothorax, some pediatric doctors might be happy to cite a chest drain who have extensive neonatal training or experienced in the process, might be able to cite a chest drain if you're struggling to continue to ventilate with needle aspiration only, and you need to get on and do that before the retrieval team arrives. In terms of equipment, try and minimize your dead space. I wouldn't recommend cutting the ET tube, because the difference in dead space of doing that's fairly minimal, but look at the rest of your circuit. And if you have to bag the patient while you're ensuring the ventilator set up correctly, just do that. And if you can't get them on the ventilator and you need to keep them safe, just continue to bag them until the retrieval team gets there. Thinking about stacking that, so gas trapping can occur. So allow adequate expiration time on your ventilator, and if you're bagging, suction and physio will help with this. If you do have prolonged expiration and gas trapping, again, wheeze, this is almost always due to secretions. So adding bronchodilators or using sevoflurane is very unlikely to help. Focus on clearing the secretions. And if you use sevoflurane, you are likely to end up causing a bit of hypotension and not helping in terms of the airway obstruction. And the reason why I'm highlighting this is because I have seen it done numerous times by people who are really trying to do the best they can for the baby, but maybe aren't as familiar with the pathology that they're dealing with. While you're waiting on the retrieval team, start your IV fluids at 70% maintenance. Recommend that you use normal saline plus dextrose, 5 or 10%. These babies will need sugar, or if they're not being fed and they've been not feeding very well for several days and they're sick, they will drop their blood sugar. So they need some sugar in their fluids. And if they're very small, very new, they might be 10% rather than 5%. Establish your intravenous sedation as per your regional transport team policy. So in our region, that would be morphine and midazolam. And you can give rocuronium boluses as required to keep the patient still and to help ventilate them. Try to ensure there's at least 2 working points of peripheral IV access. Central lines and arterial lines are generally not required for babies with bronchiolitis, and we wouldn't insert these as standard when we bring them to PICU. We would not expect you to insert them either. Once you've got the baby established on the ventilator and got them tubed, you can do capillary or venous gases to kind of see what your initial gas is, and then you can monitor them by looking at their tidal volume on the ventilator, looking at their end tidal and their pulse oximetry trends to monitor the ventilation at that point. You don't need to do gases very frequently if everything's stable from that perspective. And always discuss with your retrieval team or PICU if you're concerned, and review the diagnosis if things don't add up. So all the things that people have been talking about in the other talks in terms of collapse neonates, cardiac, always think about those things. Again, because you've seen 100 bronchiolitis already today, it doesn't mean that this one, who looks like a bronchiolitis, isn't something a bit different. So do review your diagnosis if they're not behaving the way they should. And what happens in ICU, just to finish up? Well, in our unit in Belfast, usually we will change to a nasal ET. We don't want you to do that in the DGH. If you've got a secure oral airway, there's no need to go messing about with it. But we will change it to a nasal ET, usually if we've got a stable patient who we're ventilating quite well, so that because it's more comfortable for the baby and means we get to use less sedation. We'll start enteral feeding as soon as possible. The babies aren't routinely muscle relaxed. We want them to spontaneously breathe. We'll get some physio and ET suction to help clear the airways. And we'll kind of allow them to have a relatively high PCO2. We'll allow their SATs to kind of run 88 and above, and we'll aim to extubate them sort of 48 to 72 hours later, sooner if possible. And that's everything. I'll run through that quite quickly. I'm happy to kind of take any questions now if there's anybody has anything to ask about. Thanks everybody for listening. I hope that was useful.